Welcome to Board Pearls. This is episode 2 of 4 of the biliary tract disease chapter in the pancreatic and biliary disease module. This episode is the less common gallbladder presentations: Mirizzi syndrome, porcelain gallbladder, Gallstone ileus and Bouveret syndrome, gallbladder polyps, and the functional gallbladder disorder where the main risk is overtreating. The thread running through all of these is the same. Chronic inflammatory remodeling around the gallbladder distorts the anatomy enough to change either the operation, the cancer risk, or the diagnostic frame, and the episode is about recognizing that remodeling early enough to act on it. Start with Mirizzi syndrome, the most dangerous version of the pattern, where a stone impacts in the cystic duct or Hartmann pouch and over time compresses the adjacent common hepatic duct from outside. The patient is usually a woman over 50 with long-standing stones, presenting with right upper quadrant pain, fever, and jaundice, so the full Charcot triad shows up in most cases, with elevated liver enzymes and sometimes concurrent pancreatitis. The reason Mirizzi matters more than a routine stone is what the chronic inflammation does to the wall between the gallbladder and the bile duct, because over time, the impacted stone erodes through and produces a fistula between the gallbladder and the duct, and the C-SEMDIS classification stages that progression and tells you what operation the patient needs. The first stage is external compression alone with no fistula, where cholecystectomy suffices. The next is a fistula involving less than a third of the duct circumference, needing primary repair over a T-tube. The next involves up to 2/3, and the one after that is complete destruction of the duct wall, and both of those require a hepatocoagulanostomy because there isn't enough native duct left to repair. And the last is the cholecystoenteric fistula variant, the same mechanism eroding into bowel rather than duct, which lives in the Gallstone, ileus, and Bouveret world coming next. The staging matters because the reconstruction follows from it, since a surgeon who walks into a deep fistula expecting a simple cholecystectomy is the one who creates a bile duct injury, so imaging has to answer the staging question first, and MRCP is the study of choice because it shows the stone, the duct compression, and any fistula without instrumenting anything, while ERCP is only temporizing, since sphincterotomy and stenting can decompress the system, but the impacted cystic duct stone usually can't be pulled from inside the lumen. The operative danger is why recognition reshapes the case, because dense inflammation effaces Calott's triangle, so the cystic duct, cystic artery, and common hepatic duct stop being distinguishable and become one inflammatory mass. And a laparoscopic approach there has a high rate of duct injury, so the right move is open conversion, intraoperative cholangiography to define the duct, and readiness to reconstruct. The other consequence of all that transmural inflammation is gallbladder cancer, present in a substantial share of Mirizzi cases, because the same metaplasia to dysplasia to carcinoma sequence that drives stone-associated cancer runs faster in a wall under chronic pressure necrosis. Porcelain gallbladder is the other end of the chronic inflammation spectrum, where the wall calcifies, seen in a small fraction of cholecystectomy specimens, usually with stones, so the underlying mechanism is the same chronic inflammation as Mirizzi, without the impacted stone geometry. The old teaching was that any porcelain gallbladder carried a high enough cancer risk to warrant prophylactic surgery, and the modern teaching reverses that for one specific pattern while keeping it for the others, with the discriminator being whether the calcification is mucosal and incomplete, or complete and circumferential. Mucosal or incomplete calcification is patchy, often selective for the mucosa, leaving large regions of viable epithelium between the calcified zones, and those viable regions are where dysplasia can progress to carcinoma, which is why this pattern carries the higher risk. Complete circumferential calcification means the whole wall is calcified transmurally, so the mucosa that would have been the substrate for dysplasia has been replaced by inert calcified tissue, leaving a fibrotic, burnt-out wall with no live epithelium to turn malignant. That's why the recommendation now separates them. Mucosal, incomplete, or focal patchy calcification remains an indication for prophylactic cholecystectomy in any fit patient, while complete diffuse calcification can be observed in selected high-risk surgical patients with counseling because the cancer substrate has effectively been destroyed and the operative risk in a fragile patient is no longer clearly worth it. On a stem, the asymptomatic elderly woman with a thin curvilinear rim of mucosal calcification gets a cholecystectomy, and the frail patient with circumferential transmural calcification and no symptoms can be watched with the conversation made explicit. The next presentations come from the same inflammation eroding into a different organ. Gallstone ileus and Bouveret syndrome are the bowel obstruction syndromes of a cholecystoenteric fistula, where repeated ischemic pressure necrosis of the gallbladder wall against an adherent loop of bowel perforates and seals to the bowel lumen, forming the fistula, most often into the duodenum. Once the fistula exists, two things follow. Air refluxes from the bowel into the biliary tree, which is the pneumobilia you see on imaging, and a stone can migrate from the gallbladder into the gut, where the impaction point determines the syndrome. A stone larger than about 2 centimeters that migrates distally tends to lodge at the ileocecal valve, the narrowest small bowel segment, producing mechanical small bowel obstruction in an elderly woman, often with little prior biliary history, because the fistula itself may have been silent, and the classic radiographic triad makes the diagnosis: pneumobilia, mechanical small bowel obstruction, and an ectopic stone outside the right upper quadrant, with CT more sensitive than plain film for all three. The same fistula with the stone impacting proximally produces Bouveret syndrome, where the stone lodges in the duodenal bulb or second portion, and the patient presents with gastric outlet obstruction instead, with non-bilious vomiting after meals, early satiety, weight loss, a succussion splash, and a hypochloremic metabolic alkalosis from prolonged vomiting, along with the same pneumobilia and now an ectopic stone in the duodenum. The proximal versus distal distinction matters therapeutically because the duodenal stone is within reach of an endoscope, so mechanical, electrohydraulic, or laser lithotripsy can fragment and extract it endoscopically. And that's the preferred first-line approach in Bouveret because it spares an elderly comorbid patient an open operation, with surgical duodenotomy reserved for endoscopic failure, while the ileocecal valve stone in gallstone ileus is too distal for endoscopy, so the operation is enterotomy with stone extraction. The other decision is whether to take down the fistula and remove the gallbladder at the same operation, and the instinct is to do everything at once. But the evidence runs the other way, because adding a cholecystectomy and fistula takedown to an enterotomy in an elderly patient with cardiac and renal comorbidity raises perioperative mortality enough that a staged approach is usually correct. Enterotomy first, and the fistula and gallbladder addressed later only if symptoms recur, which most patients don't require because the fistula often stays asymptomatic. That moves into polyps, which test on a different principle, where size is the dominant malignancy discriminator, and the guidelines walk the size threshold down whenever a patient feature raises the pretest probability of cancer. About 1 in 20 ultrasounds shows a gallbladder polyp, and the large majority are benign, and the frequency breakdown lines up with the imaging. Cholesterol polyps are the majority, small and often multiple and hyperechoic because they're focal cholesterolosis. Adenomyomatosis is next, almost always fundic, with wall thickening and a comet tail artifact from the mucosal pseudodiverticula penetrating a hyperplastic muscle layer. Inflammatory polyps are a smaller share, small and often multiple, and the ones that matter, the adenomatous polyps, are a small minority, homogeneous, often solitary, isoechoic with liver, and smooth, the precursor lesion in the adenomatocarcinoma sequence for a meaningful subset of gallbladder cancers and the reason the size threshold exists. That threshold is 10 millimeters, and it's empirical, because most gallbladder cancers occur in polyps at or above 10 millimeters, so above that size, the probability of harboring or progressing to cancer is high enough that cholecystectomy is justified regardless of other features. Below 10 millimeters, the operation depends on risk factors, so a polyp in the 6 to 9 millimeter range warrants cholecystectomy if any one feature is present: age over 60, primary sclerosing cholangitis, sessile morphology, including focal wall thickening over 4 millimeters, a single rather than multiple polyps, Asian ethnicity, or documented growth of 2 millimeters or more on serial imaging, because each raises the malignancy probability enough to cross the threshold where surgical risk is justified, and the growth criterion deserves emphasis as the highest yield malignancy signal across the whole. Sclerosing cholangitis is the exception that drops the threshold further, because its baseline gallbladder cancer risk in the low single-digit % lifetime and higher in some surveillance series, is high enough that any polyp warrants cholecystectomy under one guideline and an 8 millimeter threshold under another, so it's not a watch-and-wait disease for polyps. An annual ultrasound is part of the broader surveillance. For polyps under 5 millimeters without risk factors, a repeat ultrasound at 12 months suffices, and for 5 to 9 millimeters without risk factors, a repeat at 3 to 6 months, on the principle that surveillance detects the growth that would push you to operate while small polyps stay low risk in the interval. The polyp framework feeds the broader gallbladder cancer biology. Gallbladder adenocarcinoma is the most common biliary tract malignancy, with a female predisposition, faster growth than cholangiocarcinoma, and low 5-year survival because most present at an unresectable stage, and the risk factors all trace back to chronic inflammation or exposure-driven mutagenesis. Stones are present in the large majority, and stones 3 centimeters or larger carry roughly 10 times the risk of small stones because chronic mechanical irritation drives the metaplasia-dysplasia-carcinoma sequence. Pancreatic or biliary malfunction is worth holding as a separate mechanism, because the pancreatic and bile ducts normally join inside the sphincter, so pancreatic enzymes never reflux into the biliary tree, whereas a malfunction is a long common channel, 8 millimeters or longer, with the junction above the sphincter, which permits enzyme reflux and drives chronic inflammation. So in the cases with concomitant cyst dilation, the biliary malignancy risk rises broadly, and in the ones without dilation, the gallbladder bears the brunt of the refluxate and cancer develops in roughly a third of those patients. Other risks compound the same biology: porcelain gallbladder with its calcification pattern logic, adenomatous polyps, chronic salmonella carriage, high-risk ethnicities, the inherited polyposis and Lynch syndromes, inflammatory bowel disease, obesity, and environmental toxins. Late presentation is the rule because early gallbladder cancer looks like benign biliary disease, with right upper quadrant pain and dyspepsia that nothing distinguishes from biliary colic until the tumor invades the structure, so bile duct invasion produces jaundice, portohepatis invasion produces cholestasis, and peritoneal involvement produces ascites and weight loss, by which point most patients are unresectable, and radical cholecystectomy with hepatic segmentectomy and lymphadenectomy is the only curative option and works only in early-stage disease. The last presentation is the one where the trap is over-treatment. Functional gallbladder disorder is biliary-type pain without structural disease, so the pain has to be biliary in character, epigastric or right upper quadrant, at least 30 minutes long, severe enough to interrupt activities, and not relieved by bowel movement, antacids, or posture, and the workup has to be clean, with no stones, sludge, or microlithiasis on imaging and normal liver chemistries and pancreatic enzymes. The discriminator everyone reaches for is a CCK-stimulated HIDA scan, where a gallbladder ejection fraction below 35% has traditionally been taken as supportive that the gallbladder is the source, but the evidence behind that threshold is contested, because pooled analyses concluded the data supporting ejection fraction as a predictor of relief after cholecystectomy is lacking, and many patients with biliary pattern pain, no stones, and a normal scan still improve after surgery, which suggests either a placebo response or that the disorder. The overutilization is concrete, because biliary dyskinesia has become a common indication for cholecystectomy, especially in the United States, and strikingly in pediatric patients, at rates well above other developed countries, and the dominant trap is overlap with functional dyspepsia and irritable bowel syndrome, both of which produce epigastric or right upper quadrant symptoms unrelated to gallbladder physiology, and both of which respond to cholecystectomy at placebo rates. The stem that gives it away describes daily meal-related fullness or pain that improves after passing stool, sometimes with occasional right upper quadrant episodes, which is functional dyspepsia, or irritable bowel with incidental gallbladder findings. And cholecystectomy, there doesn't relieve pain but does expose the patient to operative risk and post-cholecystectomy bile acid diarrhea. So the selection has to be strict. Fully met biliary pain criteria. Structural disease excluded on quality imaging. Functional GI disease optimized first because a response to neuromodulation reframes the diagnosis, and only then is a HIDA scan worth considering, with explicit counseling that even in well-selected low ejection fraction patients, the response after cholecystectomy is only around 60%, so a meaningful minority don't improve. That counseling also frames the follow-up, because a patient with persistent biliary pattern pain after a low ejection fraction-driven operation often needs further imaging before invoking sphincter of Oddi pathology, since the original low ejection fraction may have been a marker of underlying functional GI disease rather than gallbladder disease, and chasing the next anatomic explanation often just produces another negative workup and another low-yield procedure. Pull the episode together at the level of principle. The uncommon presentations reduce to a few patterns. Chronic stone-driven inflammation at Calot's triangle either compresses the bile duct from outside, which is Mirizzi, calcifies the wall, which is porcelain gallbladder, or erodes into adjacent bowel, which is Gallstone, ileus, and Bouveret, and the stage of that inflammation sets the operation in Mirizzi. The calcification pattern sets the cancer indication in porcelain gallbladder, and the level of stone impaction sets endoscopy versus surgery in the fistula syndromes. Polyps test on a clean size rule, with risk factor modifiers that walk the threshold down, and functional gallbladder disorder tests on the discipline not to operate, because the failure mode is over-treating a heterogeneous category. The next 2 episodes take the chapter into the bile ducts proper. The first covers the acquired duct, cholecystostomy with its risk stratification and acute cholangitis with the timing for decompression, and the second covers the structural and iatrogenic duct, choledochal cysts and Caroli disease, bile leak and post-cholecystectomy stricture, and sphincter of Oddi dysfunction as it's now classified. For the full chapter, the practice vignettes, and the topic tag question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 2 of 4 of chapter 27, and I'll see you in the next one.